Here we will discuss a carotid artery occlusion and revascularization using the solitaire platinum. This is a 61-year-old woman who was found down by the family and brought to the emergency room with altered mental status and left upper and left lower hemiparesis. She was seen normal 12 hours prior. On exam, she was lethargic and not following commands, aphasic with a left facial palsy, left hemiparesis, neglect, and hemianopsia. Her NIH stroke score was 15. Her past medical history was significant for comorbidities of hypertension, diabetes, coronary artery disease, and atrial fibrillation. CTA demonstrated right intracranial carotid artery bifurcation occlusion, and CT perfusion showed increased time to peak but preserved volume on the right hemisphere. She clearly was a candidate for endovascular therapy. Here we have the CT perfusion showing increased time to peak as the red area, but preserved volume and flow. The CT angiogram shows a bifurcation lesion and a proximal M1 lesion, all on the right side. The devices we used were an 8 French sheath, a 6 French guiding catheter, a microcatheter microwire, as well as a solitaire platinum 6x20mm device. Here you can see she has a relatively straightforward access route into her right internal carotid artery through the aortic arch. Here we can see proximal guiding catheter is brought up. An intracranial run is done, and we can see occlusion in the ICA intracranially. Here we demonstrate using microwire and microcatheter techniques to advance past the site of occlusion, which is at the level of the posterior communicating artery. In this case, we're using a triaxial system with an intermediate catheter, a microcatheter, all within the guiding catheter. The intermediate catheter is brought very distal, giving us purchase and stability, while the wire is navigated into the M2 region. We will then follow this with the microcatheter as we cross the thrombus, allowing us to then bring up the solitaire device in a distal fashion. Occasionally it may be difficult to maneuver the microcatheter past the thrombus, and therefore we need significant distal wire access. Once the wire is across the thrombus safely, we can then bring the microcatheter across the thrombus. Here we can be seen doing a microcatheter run, showing that there is no significant distal thrombus in the MCA candelabra. Once we're confident that there is not a shower of emboli or there are not multiple vessels filled with thrombus, we will bring the solitaire platinum up. Here you can see the solitaire platinum being maneuvered into the distal part of the microcatheter. And now we're deploying it under high resolution, high magnification in the distal M1 segment. What is optimal about this device is there are many parts of the device that have markers, so we can see how the device opens within the thrombus. You can see that one set of markers is still impinged, suggesting that we're across the thrombus. Using a staccato type technique, we pull the solitaire device under aspiration techniques. We can see how distal the intermediate catheter is now, right at the bifurcation, which is under aspiration. And therefore, with a stent retriever and aspiration technique, we remove both devices and hopefully restored flow. We can see here that the ICA is open completely. The A1 segment of the anterior cerebral artery is filling, but there's still thrombus in the M1 segment. Therefore, we need to return and recanalize the MCA. While we have progress, it is inappropriate and insufficient to leave this thrombus in the MCA. Here we have further purchase with the microcatheter so we can deliver the solitaire platinum into the M2 segment and cover more of the M1 segment with the retrievable stent. You can see one portion of the retrievable stent is still impinged, telling us that there's thrombus there, while distally the stent tines are open. That is an advantage of these markers across the solitaire platinum. We bring our intermediate catheter into the M1 segment under aspiration technique and repeat what we did in the previous step. We're using a staccato pull method under aspiration to remove both the catheter and the stent retriever. Here, diagnostic angiography shows complete recanalization, TICI 3, of an ICA terminus occlusion.